suddenly had mandatory CME for all performers. And that was something that I could never do, but that they could ask for this year. But the biggest thing about the CME was that it's very, very practical. There's one talk that we're using where I am now called Managing Hypertension with $4 a Day. And it says step 1, step 2, step 3, step 4. And that really helped. One thing that was that I thought was kind of cool was at these meetings we would have physicians inject themselves with an insulin pen with sterile saline in it. And it just gets, because the literature shows there's this big hesitancy. Patients, they'll be on oral meds and then they need insulin, but there's a big delay in clinical inertia until they get on the insulin. So by having people actually inject themselves and say, oh my God, it's a lot easier than sticking the finger, they can actually tell that to patients. I don't know, I like the idea. I don't know how much impact it had on patients, but that was fun. Okay, now the second part is finish it. We have another hour and 20 minutes. Oh, okay. So leadership is everything. So and then just talk about some of these ideas. So just the whole idea is we worked a lot on leaders sharing these ideas and getting them spread out and working solely through the leaders. These tips, you're just one half of the whole without the leadership being able to work. First thing we always start with is establish what are we fighting for, and so we all we know the evidence. We had evidence sheets actually, which were very powerful, it turns out, with the the literature citations of what the rationale for what we're doing. So and those are some examples up there. Let me move on. This is reduction in risk estimates, and this one, the simplified ones, that would be even more helpful, particularly for staff, so they can see just what we're talking about. And it really has a big impact on people. So by having the what are we fighting for, then it would give people courage to talk to their partners and talk to their groups about why we need to do this. And that was very, very important. As everyone here knows, no physicians, very few physicians, learn any leadership or management in medical school. And so by arming them with truth, it was easier for people to speak their mind or speak to other partners. Execute a specific communication plan that includes the staff. You saw some of the messaging. We would teach that to the staff too. It's very, very important. The staff were hearing about the patient's disgruntlement in the background. Or they were suddenly expected to work a roster and they didn't know why. So once we told them that they were going to be saving lives, it made them feel a lot better. In fact, the medical assistants, they really got on board with this and they were driving it sometimes. They would bring the rosters, and it varied, of course, but mine, I remember I saw this young man, low socioeconomic status, very unreliable, and bounced from several other doctors, and he came in, his A1C was 12. And you tried to get him back, and he left, and Monica comes after me and she goes, oh, Mr. So-and-so, he's going to hurt us. Meaning our scores. We're not seeing Mr. So-and-so again. That's going to be a problem. We at Alina and where I'm now have pair leadership structure. So in the office it would be a manager and a lead position. So they're kind of paired on everything we do. The manager's job was quality was just as big as the physician's job.
Well, that's really interesting. Could you elaborate on that a little bit? I mean, I've never heard of that other than CDC.
Well, there's quite a few places that I think are starting to use it. The idea is, so I was chief medical officer and there's a vice president of operations who was under, which is the religious manager of the group. Then in our districts, there were 6 of those, 100 doctors. There'd be a medical director, or a district medical director, and a district director. Then at the clinic level, there'd be a lead physician and a manager. So when there's talking to the staff, the manager would say to the doctor, hey, come with me to the medical assistants meeting. I want you to kind of give the pitch on this. Or whatever it is, they always work together to get these things done. Guiding coalition, bringing the leaders together to talk about what worked for them and what didn't work. That was very helpful in spread. Very helpful, much more powerful than active guardian. Establishing the moral high ground. talk about some of these ideas. Don't talk about the numbers. Talk about patients. Use chart reviews. But then when started to argue that, oh, it's not fair, my patient is sick and all that, always devolve down to, well, let's just look at your list and see if there's anyone there that can be fixed. And there always is. Evidence-based practice, highlighting new sites, new workflows at different sites, so we can come back and report to the others. That was very, very big, very powerful. 4 times a year, we bring the lead physicians and the managers all together, and then whoever was highlighting the latest thing would get up and talk about what it was, and we'd break into small groups. Well, how did you implement this? It could be that or open access. How did you implement open access some years ago? How do you do that? How do you do that? We would teach each other. And very important to teach that consistency breeds reliability. You know, no one wants to fight for standardization. But over time, you know, we get new doctors coming in and they'd say, boy, this place is like a well-oiled machine. Yeah. This is one of the most important things that we did for the staff and for the doctors to some extent, for me to a large extent. You know, once you decide something, you gotta go all the way. You can't stop short. You just can't, because that will kill you. So we would either make, you know, we'd have standards or guidelines, or we wouldn't, or we'd be just silent on what should be done. And that was very important because you didn't have like the flavor of the month there. Hey, you ought to try this, you ought to try that, you ought to try the other thing. We tried fewer things, but made sure that they had evidence behind them that we went all the way. And then teaching leaders to lead. This is very, very hard because at some point, you know, someone would have to talk to the person who's lowest and say, hey, you know, your list or your patient's numbers are different than everyone else's. And let's talk about that. And that wasn't an easy conversation. And we had to teach in some of these workshops we would do. We would actually do role play and things like that. How do you talk to them like that?
Dr. McCarthy, on doing that, did the non-blinded bar graphs help at all in those doctors that weren't performing well?
It did, and yet it wasn't enough. It was very helpful, very powerful, especially in some clinics. In other places, you know, sometimes there's pushback. You know, it's all about the numbers. That's all they care about.
Right.
And, you know, that sort of stuff.
Because we talk to doctors and it's like, but my practice is perfect. You know, and they're just blown away that the numbers are so low.
And some are paralyzed. Some don't want to really admit they don't know what to do next. They're not sure why. And then you give a visit to think I'm doing the right thing. I can't explain why my numbers are different. I really can't explain it. It seems like patients won't hear what I tell them to do, which is part of it.
I'm sorry. How did you look through the QMI? Who reviewed those and how did you leverage that information? Looking who's hospitalized, who had an event, and then going back and say, hey, could we have prevented this?
Yeah. I just used this recently, actually. And I'm going through this, I'm sort of like going back in time because the group, my group now, we're not all there. And I was having trouble here with the medical directors, with the regional medical directors, and sort of talk to your group, this is important. Oh, this and everything else is important. So we started, most recently, we just bound these and then we'd abstract the case and show the care over the last year and a half. And so I just gave it to them. I said, it's not like at any given appointment, nothing was wrong. But you see what happened? They drifted along and they had a heart attack. And he changed. You know, it seemed to be enough. You started paying attention to realizing that simple thing is big.
This was with his own patient?
It wasn't with his own patient. I actually had two. One was his, and one was another one. But you know what? Because we're all pretty blind and pretty stripped down. He asked me. He said, "Is this my patient?" I said, "No, I think it's one of the students." So yeah, it wasn't. I don't want to. So that's what we did. And you just read that and you just see the gap. But I said, "It's a process issue. It's not bad doctoring. I mean, it's just happening." And so that was powerful. Taking those things. Yes.
Can I share something with this group that's from a consumer's perspective a little bit? So everyone in here has had a great influence on me personally. So I went and did something because I'm becoming more informed as a consumer and because I was getting to a very overweight place in my life. So I decided I would sign up for a weight loss program. And every weight loss program that I went into it didn't work for me. Been yo-yo dieting, going to here, I'm the Chronic Care Coalition, I'm working on a Heart Healthy San Diego. I have to walk the walk because I'm talking the talk. And plus, I know that my numbers are going up, okay? So I started this weight loss program. 2 physicians had it. Really strict, really strict. It's Kaiser. It's the best thing I've ever done, okay? I'm 25 pounds less in 4 months, but that isn't the big deal. The big deal is when I went in there, and I would be happy to start sharing the data on me personally now because I have graphs and everything. Because every 2 weeks we're doing non-fasting blood work, and we just did fasting blood work last week, and those labs are coming in right now. And so I've been able to really, so what you're saying today is right on point, because now as an informed consumer, I am excited about the direction we're taking, and every week we meet with the group. And I don't want to miss those. And it costs us a lot of money to go. So the incentive for me is I better not miss it. But it's more than that now. It's more because I'm feeling better and my numbers are amazing. I was at borderline high blood pressure, 140/80 up to 90, bouncing around in the 150s. I'm at 116/76 now. 4 months. And it's staying down, and my energy is up, and it's really exciting because but it's exactly what we're talking about, what we're trying to do here, and so what I'm hearing from you, which is so exciting what you're doing in your practice, could you take, as we're activating patients and what we're doing here, take that kind of patient activation and maybe even broaden it more to where there's a nutritionist in the room, or you're saying, the doctors make appointments for us. If I'm late, because I get off work late and I have to go in there late, Dr. Ishihara wants to see you. You haven't been there yet tonight. I said, I have to go tonight. She says, I'm walking you in. They almost hand walk us over there to see him, and then they go over everything. So it's a very strict, very carefully planned program, but it's awesome because every single one, there's 10 of us in our little small group. We have lost 387 pounds in 4 months.
For some patients, that sort of being more forceful or something, being more direct, it works. And instead of bugging them to come in or what have you, it works. I had this dentist in Minneapolis. She's a great dentist. Actually, I don't know if she's a great dentist. How can I tell? I'll tell you what she did do. Her staff would call and bug me. And I'd go, I don't have my calendar. They'd call me again. And I would get in there every 6 months or whatever. I thought, what a great dentist. I hope she's good too. Who knows? Anyway, this leadership thing, I can't stress enough. And if we'd had more time, we would have done a little bit of role playing. And that's probably what I would think was the greatest leverage, was getting one physician to talk to another about, hey, what are we trying to do here? That was big, because that's something that you can't do from your leadership positions. It's usually got to be someone vocal in the clinic talking about it. And they talk about champions, but no one says exactly what a champion is supposed to do. But part of it is just to bring the knowledge and get people excited, but part of it has got to be sort of having that difficult conversation.
I have 2 questions, but I've already asked several, so if someone else wants to go
Just,
first.
we can handle 1 or 2 more questions. Any other questions? Go for it.
Oh, I do have one. Your numbers are so high. I mean, they're really high, 20% above many people. I'm beginning to think some of it is you. and I want to ask you, why are you motivated to not just kind of hit the very top, but to just keep going?
I think it's names on the list.
Honest answer? That's a great answer. That's fantastic.
Years ago, this is back when I was in Michigan, we first got our first data and all that kind of stuff. And I thought, we're all thinking we're great, right? I always thought I was good. I thought I was better than most. And I got my diabetes scores. I was a little better. More than that. And I thought, how can that be? And the biggest impression was Fred Whitehouse, Dr. Whitehouse, endocrinologist, head of the American Diabetes Association, Center for whatever, real eminent cardiac. I said, Fred, what am I doing wrong? What am I, me and my partner, what am I doing wrong? If I could give you one piece of advice, Bruce, don't just stand there, do something. And he was so right. This clinical inertia is so pervasive. Anyway. I'm surprised no one asked about doctors trying to get rid of patients from their panel.
I had a note, I didn't want to ask about it. I was actually wondering if anybody's done, somebody like Cheryl Danberg at RAND, who's done a lot of work on the impact of like P4P programs and the way behavior changes on those incentives. So I have a little note to look up and see if anybody's done it. I published an article that looks at that sort of cherry picking, because you hear about it anecdotally. I mean, I've done interviews with physicians asking them about how they feel about their P4P programs, where they literally tell me anonymously over the phone how many patients they booted off their panel. Because, I got to a point where I was sick of knowing that he'd walk out of my office and go order a cheeseburger, so I just don't see him anymore. And you sort of cringe and think that guy's walking around somewhere, and you'd like to think he would find a home somewhere else with somebody who might motivate him along the lines.
He just got on my panel.
What?
He just got on my panel.
I think some of this goes on. We didn't pay for quality scores. That's a whole other talk. Because I think it gets confusing. Does it change behavior? Yeah, I'm pretty sure it does. Does it help more than it hurts? Not sure.
Most doctors will respond, I provide the same quality of care whether I'm getting paid for it or not. I want to do the best by my patients. I genuinely think that's the way.
By not having that, it actually made the conversations easier. It wasn't.
Probably so.
I'm not
It's not punitive.
grading you. I'm not giving you money or taking money away from you. I'm just asking. Is Mrs. Smith getting the best care? Is she getting everything science has to offer? That's all I'm asking.
One thing we could consider doing is having a patient responsibility. Like you do with the pain contracts, but this would be for everybody. In other words, come on time for your appointment, don't show, take your medications, make life changes to help become involved in the care, work with your physician. Maybe we should think of that. We thought about it with pain contracts, but maybe we should think about a patient responsibility. We have ours, but maybe it works both ways and publish the product, just that.
Making a commitment and signing it is supposed to be important for behavior.
It's key, yeah.
But there's one thing I just want to say though, I think you've got to be careful because usually early on when you start to talk to a group of physicians, they'll talk about the non-adherers and they ought to be punished somewhere and things like that. And I tell them just to work on the others right. Yeah, there are those.
For those who genuinely have a will to change, and maybe don't.
They're the ones that we're letting drift along for 12 months, every 3 months. Diet and exercise encouraged. So patient hasn't taken the medicines the last 2 days. We'll recheck at the next visit.
Yeah, I think the true quote-unquote non-adherence is much smaller than what we think. We did the A1C plus greater than 9 project, and that was the first thing. They looked at us. No, I know all those patients. I'll never get them off. And lo and behold, they started doing things like Bruce said, got them off the list, and we had doctors with 0 patients, 9 or above. It was truly amazing how few patients were really in that quote-unquote non-adherent. It really was amazing to me.
Yeah, but the question is, did their A1C come down or did they get off the list? New York State for years has published physician-specific outcomes from CABG surgery, and it's well documented that the number of high-risk patients undergoing surgery has gone way down, and so mortality statistics are better, but not necessarily care.
think you have to worry about that. And I do know that some, I know that one physician who was the highest in our group, I do know, or at least more than one person told me this, that he was just a very kind of, a certain kind of doctor, kind of very authoritative type, and explained that this is my treatment philosophy, and I hope you're comfortable with it. If you're not, you know, well, that would be okay too. No hard feelings. So I think that happened. There was talk about from this other health system in Minnesota where doctors got paid actually a lot of money for their quality scores. That we were getting patients who would tell us, yeah, they kind of fired me. But you had I want to get back to you.
The there will be a thread through this. How did your providers, or how did you, or how did everybody respond when the change went from an A1C of 7 to 8, or the lower blood pressure to the higher blood pressure? What was the message, and how did they respond that their target had changed?
Well, that was an interesting time. And I just got a letter actually from someone after I moved to Milwaukee saying, see, because after the Accord trial came out, they moved it from 7 to 8 on the A1C. I don't know. I don't know. I think one of the things is I think that when you're leading people, I think you should try to be an evidence hawk. And I wish I had knew that before. And so you stay where there's really, really, really good studies that this is important. And then really draw a line and be really, really tough on those things. But other things where it's grayer, don't push so hard. So when the numbers changed, some people said, aha, see, this is all arbitrary. And I'd say, and we had a lot of discussions about it and at the Clinical Practice Council. And that, you know, I think the message we were trying to put out is, it's still true that an A1C less than 7 reduces microvascular disease. Didn't change. Didn't change. And in fact, if I had diabetes, I don't. And I want my A1C less than 7. Absolutely. But in the larger sense is, things will always change as we get new knowledge. And so you can either be, what do they call that? I don't know. I can't remember the word, but it sort of doesn't believe in anything. A nihilist doesn't believe in anything. Where you can say, well, this is our best body of knowledge right now. Let's go for it, because that's the kind of doctor I want to be. That's the kind of doctor I think we want to be. So yeah, it was kind of a tough time, and those things change and make it a little harder the next time when you do it. But I think now I think most groups across the country are getting more evidence-based, be tougher on this. Even aspirin, which is in our bundle. There's no RCT on aspirin and diabetics.
In the United States, the Preventive Health Services Task Force actually recommends that it's not necessary.
Right. So anyway, getting the Minnesota Community Measurement off some of these things took some time. I don't know. Not a great deal.
Of course, they also
really
recommended mammography was not necessary. So
Well, let's be fair. They didn't say it wasn't necessary. They said every 2 years after age 50. And that's what the data says, which is saying. Just one other thing, because the follow-up to that, I think, is important. I'm on the group that said all those, the less than 7, less than 8, the blood pressure changes stuff. And it is me, and I apologize that they messed up the first time and had the low standards. They shouldn't, they made the mistake. But related to that, you're, I hope not unique, but you're certainly unique to the people I talk to. This 73% grade A performance, in my mind, is dangerous, and it's bogus, and you don't live by it. Instead, what you do is you look at the individual patient and you decide how to best care for the individual, and it turns out that this arbitrary number that has no basis in reality you happen to cross it. And so I just want to compliment you on that, and I hope that all of us can start treating patients and do it better rather than aim for an artificial dotted line across a graph, and I just needed to applaud you for that.
Well, on that note,